θερμά για την παρουσίαση και θα ήθελα να ευχαριστήσω για την πρόσκληση τον καθηγητή τον κύριο Δελιγιάννη, την κυρία Κουίδη και τον κύριο Κουτλιανό. Θα κάνω την ομιλία μου στα αγγλικά γιατί έτσι την ετοίμασα έχοντας και ξένους ομιλητές. Οπότε θα συζητήσουμε τα exercise recommendation individuals with channelopathies. This is my only conflict of interest. I work very closely with a wonderful charity called Cardiaques in the Young, and I will invite you to go and visit their website. Now, what I'll try and explore over the next 15 minutes is outline some basic principles of exercise prescription, and some of you will know them much better than I do, and then briefly discuss long QT syndrome, CPVT, and Brugada syndrome. If there are a couple of documents that you want to go and read, these are the ones I will recommend. The ESC guidelines we published last year, but also the recommendation document from EAPC and ERA that was published before that, which actually may be a bit better off in terms of the ion channelopathies. Now, I will start from this because I think this is a very important point. We know that exercise has multiple benefits in our cardiovascular and overall health and well-being. So I will argue that you need to fulfill those as minimum recommendations, which are the World Health Organization recommendations in terms of physical activity, which quote 150 minutes of moderate intensity or 75 minutes of vigorous intensity exercise, which must be combined with strength training as well as exercises to improve the balance. So to go below that, you really need to have really good evidence to support if you're restricting your patients. However, the problem is that we have always had concerns in terms of cardiac conditions and exercise, and our concern is whether the adrenergic surges in the context of an unstable electrophysiological substrate can provoke ventricular arrhythmia and sudden cardiac arrest. And we know that ion channelopathies may account for a significant proportion of sudden cardiac death in athletic individuals. And here you see our experience where 40% of deaths were due to a completely normal post-mortem, indicating an electrical rather than a structural fault. And this has been reflected on the recommendations in the past, which I have to say have been extremely, extremely restrictive. Now, when you assess as a general principle an individual's risk of exercise-related cardiovascular events in order to provide them with exercise prescription, you should follow some basic principles and go through a very detailed history and examination, assess what's the condition, what's the potential risk, what is the level of exercise they're currently doing, and what do they actually wish to do, because that's very important points in order to be able to have an informed conversation. Then you will perform the necessary evaluation to ideally re-stratify them in terms of the specific risk of exercise, and particularly high-intensity exercise on top of their condition. And then you will hopefully be able to provide some sort of individualized prescription, which I have to say a lot of the time is hampered by the lack of evidence, but also the lack of ability and knowledge from our point as cardiologists in order to provide appropriate exercise prescriptions, as it's not really something that it's being particularly well taught throughout the world. So ideally, you will end up with an exercise prescription, which is based on the FIT principle, and you'll be able to give them a frequency, the time they need to spend with the exercise, what type of sport they can do and at what sort of intensity. And as we said, we need our endurance, but also our strength training. And here is a table that we published recently for valvular heart disease, where essentially tries to describe different sorts of intensities of exercise, how you can assess them in the first half of the table, and then give some examples in terms of sporting disciplines. The reality, however, is that a lot of the sporting disciplines can happen at different intensities, particularly at a recreational level. Now, there has been some progress with the publication of the 2020 ESC guidelines because they tend to be more liberal compared to previous recommendations by re-evaluating the evidence, because as you realize, there are two ways of looking at the lack of evidence. One is to say we don't know much, so let's restrict people to try and keep it as safe as possible. While on the other hand, you may say, well, if we don't know, we need to be careful about restricting people and taking exercise and competitive sport away from them. So those guidelines provide an outline of patients' assessment. They give you a very structured approach. So I will highly recommend that you read and use this document in your clinical practice. Very importantly, it takes the individual's wishes into consideration. So that's the shared decision-making model. And it addresses exercise across different levels of exercise and not just competitive athletes. Now, if we get started, I will refer to the three main channelopathies, and this is Brugada syndrome. Due to the time limitations, I'll be very brief with Brugada syndrome because there is a larger consensus regarding exercise, but it's essentially a genetic sodium ion channel disorder to the best of our knowledge, although I have to say it's more complex as a syndrome compared to that alone. It can predispose to ventricular fibrillation, and the reality is that the majority of deaths happen at rest or during sleep and not during exercise. So only a small proportion of individuals with Brugada syndrome will suffer an arrhythmia during exercise. As such, traditionally, exercise is not considered to be a major risk factor, although there are certain concerns regarding the increased vagal tone in athletic individuals that may predispose to arrhythmias. This is the most typical ECG of the diagnostic type 1 Brugada pattern, where you've got the 2 mm J-point elevation, a curved type ST segment that comes into a negative T wave. And it's important to note that this is the only diagnostic phenotype on the ECG for the Brugada syndrome. Now, in terms of the exercise recommendations for Brugada syndrome, as I said, there is agreement between the two sides of the Atlantic. The American guidelines are a bit older, back in 2015. The ESC is the 2020. And essentially what they say is that if the individuals are asymptomatic, or if they're genotype positive, phenotype negative, and you may have identified them because of family screening, there is no restriction to sport. But even for individuals who had symptoms, and for the ESC guidelines, even individuals who have been treated with an ICD, it is possible for them to participate in high-intensity exercise and even competitive sport. But they mention a few precautions, and one of those precautions relates to avoiding extremes of sports and extremes of temperature that may elevate your body temperature above 39 degrees centigrade. So in terms of exercise precautions in Brugada syndrome, and I will emphasize that again and again, if you've got someone who has an ion channelopathy, particularly if they're very keen to participate in high-intensity exercise, whether that's competitive or recreational sport, it makes sense that they need to be under a specialist care. And it needs to be a specialist that knows about channelopathies, but knows about exercise and exercise prescription as well. Avoid drugs that exacerbate Brugada syndrome, and this is the website you can refer to. Avoid dehydration and things that may upset the electrolyte balance, or things and activities that may predispose to hyperthermia, heat exhaustion, or heat stroke during exercise. And also, please don't forget that even if it's a relatively safe condition, it makes sense, particularly for competitive athletes, that the team doctor, for example, or the organizer of the event knows that if something were to happen to that individual, they need to act quickly, rather than assume that they had, for example, a simple faint during the race or after the race. Moving on from Brugada syndrome to low QT syndrome, which is a bit more complex in terms of exercise. So again, we've got a congenital disorder. The prevalence can be 1 to 2,000 up to 1 in 4,000, and can predispose to polymorphic ventricular tachycardia and ventricular fibrillation. We know that we've got at least 12 susceptibility genes, but the ones that are more frequently identified is the ones that are responsible for long QT type 1 and long QT type 2, where we've got an issue with the potassium channels, and the long QT type 3, we've got an issue with the sodium ion channels. It's also important to remember, and don't forget that ion channelopathies and arrhythmias can also present as epileptic seizures or unexplained drowning. On the right-hand side of the slide, I've put for you the 3 typical ECGs that may help us presume or identify a particular genetic subtype of long QT. And here you've got the type 1 with a tall, with a wide base T wave. The type 2 where you've got that hump, the beefy T wave, and the long QT type 3 where you've got, the longest segment with a peaked T wave at the end of it. Now, in terms of diagnosing long QT syndrome, we've got the SFART score that takes a number of elements into account, from the 12-lead ECG, and obviously how long your QT is plays a major role. The exercise test can be particularly useful, and we measure the corrected QT interval at 4th minute into recovery, clinical history, as well as family history of the individual. It's very important to note that with long QT syndrome, we're extremely good as well in genetics, and we may identify a pathogenic variant in up to 80%, and therefore the diagnosis could potentially be a genetic diagnosis in the absence of any significant prolongation of the QT interval. Now here I've got a typical ECG for you of an athletic individual, and as you all know, what we need to do in order to identify and calculate our QT is we identify the baseline, ideally in lead 2 or lead V5, then we draw the tangent at the steepest part of the T wave, and then we choose the beginning of the QRS complex and where our tangent meets the baseline, and this is our absolute QT, and then we will calculate our corrected QT interval, measuring the RR interval and using the Bazet's formula. Now, in terms of QT intervals, we accept up to 470 in male athletes and 480 in female athletes. And the other thing that's important to emphasize is that measuring the QT interval in athletes can be challenging because they can be quite bradycardic. My suggestion to you, if that's the case, get them to do some leg raises to bring their heart rate a bit higher in the region of 60 beats per minute, so you can do a more accurate estimation with your Bazet's formula, which is the formula that is most widely used worldwide. Now, triggers for arrhythmia in long QT syndrome, there are plenty, and some of them are the adrenergic surges, and that's why we're worried about exercise. Particularly for long QT type 1, swimming, and it's not the action of swimming as such, but the immersion, sudden immersion in cold water, that may be a problem. Intense emotion and loud stimuli, particularly for long QT type 2, fear, and sometimes, obviously, we have to consider medication or drugs that athletes may consume. On the other end of the spectrum, however, the significant bradycardia that we see in athletic individuals may sometimes predispose to pause-dependent episodes of ventricular ectopy and ventricular fibrillation in individuals with long QT syndrome. Now, this is a typical individual, an asymptomatic 16-year-old competitive swimmer. And for some reason, they will always be swimmers, just to make the challenge even greater. And the question is, what will you do regarding this particular individual in terms of evaluation of exercise? And I haven't given you a subtle example. There is significant prolongation here with a corrected QT interval that looks in excess of 500 milliseconds. And this particular individual, in the absence of symptoms, what you will need to do is, I will do a transthoracic echocardiogram to ensure that he's got a normal structurally heart. And then I will do an exercise test to see the behavior of the QT during exercise and whether there are any arrhythmias. And I will also do an ECG monitor, particularly with the exercise which he's doing, if that's possible at all, or during training, in order to see how his QT behaves during real-time exercise and whether he gets any significant arrhythmias. Genetic testing will be extremely useful because it can inform us about the particular genotype, and as we say, that may be relevant, particularly in this case where he is a swimmer. Now, do we have any evidence? This is the best study we've got. It is a relatively small study from Michael Ackerman that has done a lot of work on long QT syndrome, 353 individuals, 130 athletes. And the point that Michael Ackerman tried to say is that in about 331 athlete years, there was only one event, and that event was in someone who was very young, with a very long QT interval who received ICD shocks as he was considered at high risk because he didn't get his beta blocker. Very important point though, the great majority of those individuals, as you will see here, they were on beta blockers. And that's a very important point because we need to try and put athletes on beta blockers, and that can be quite a challenge sometimes with a significant bradycardia. The limitations of the study, as most of those studies, is that we've got a small sample size with very limited follow-up, and you can see the confidence intervals, which are huge because of those limitations, and the fact that we had very few athletes that participated in high dynamic, high static sports. So these are the recommendations from the American and the European study, and you can see that the Europeans are far more restrictive. What the Americans are saying that you can compete if you had symptoms, but you are on beta blocker therapy and you have been asymptomatic for at least 3 months, okay? And you can definitely compete if you are asymptomatic or you have the genotype, but you don't have the phenotype. On the other hand, the European recommendations draw a lot of caution for those individuals who have a prolonged QT interval beyond the 470 and 480 mark that we mentioned earlier, and they suggest predominantly recreational sports. I have to say, I am an author in the European recommendations, but I tend to be a bit more liberal with my long QT syndrome patients. Regarding the exercise precautions, pretty similar to what we discussed before. Remember that particularly for long QT syndrome, there are a number of drugs that can cause QT prolongation. And again, avoid things that may predispose to electrolyte abnormalities and dehydration. And you need to try beta blockers in the athletic individual. And last but not least, we've got the Catecholaminergic polymorphic ventricular tachycardia, another genetic condition, predominantly due to ryanodine or calsequestrin gene mutations, where we've got disruption of the intracellular calcium regulation. And this particular condition is definitely related to exercise, and it's associated with the adrenergic surges. And unfortunately, the baseline ECG is a very poor diagnostic tool. So here you need the exercise test as your diagnostic tool. What you're looking for is for polymorphic ventricular ectopy or tachycardia, and you've got this typical pattern of a bidirectional. You can see that it goes top, bottom, so 180 degrees difference. And here is a typical exercise test of an individual, and I've marked for you the couplet there, which has 180 degrees different axes. And here will be a potential scenario: an asymptomatic football player who is identified with a pathogenic variant because of screening, familial screening for CPVT. And the questions you may be asked: well, I'm asymptomatic, doctor. How are you going to assess me, and can I continue competing with in football? And there are a number of options there that may go through someone's mind as to what's possible for this young individual. The reality is that you will have to investigate them extensively, reassure them that they've got a structurally normal heart, and do an exercise test and do your ECG monitor as we did before for long QT syndrome. In the absence of any arrhythmias, again, it will depend whether you go with the American or the European guidelines, and I'll explain that in just a second. This is another study by Michael Ackerman. He looked at 63 individuals, young individuals, 42 athletes, about 20 athletic individuals. And essentially, the bottom line was that, yes, CPVT will predispose you to arrhythmias during exercise. And that's why the athletic individuals were identified at a younger age. And look how much more arrhythmia they had, okay? But once you put them on good treatment with beta blockers, and that's an absolute necessity if you're going to participate in regular physical and high-intensity exercise, then the arrhythmic events become very similar. And this is what this histogram demonstrates: similar arrhythmic events, but you can see that they're far higher than the arrhythmic events that we identify with treated long QT syndrome. So here, the recommendations are fairly restrictive on both sides of the Atlantic in terms of people who have arrhythmias or symptoms, but they tend to be more liberal in terms of genotype positive, phenotype negative individuals, potentially like our football player in the American compared to the European recommendations, where tend to be more restrictive, even for those who haven't really expressed the disease. So these are the exercise precautions for CPVT, which are fairly similar. So expert evaluation and ensure that you don't overdo it while your athlete is on beta blocker. So in conclusion, ladies and gentlemen, the recommendations for competitive sport and recreational exercise in channelopathies have a structured approach. They allow for self-determination and they gradually become more liberal for long QT syndrome and Brugada syndrome. It is imperative that we give exercise prescription for everyone, whether they're going to be able to participate in competitive sport. It's something that should be individualized with our patient. And here I've put in a traffic light system the summary points for you, with green for Brugada syndrome, orange for long QT syndrome, and red due to more restrictive attitude for CPVT. And a word of caution, make sure that you get the diagnosis right and go to a specialist, because there are lots of challenges. Those athletic individuals will require regular monitoring. And please don't forget, irrespective of how safe they are, to have an emergency response plan and educate your athlete about symptoms and things that they should do. And obviously ask yourself what you're trying to achieve, because competitive sport does not definitely equate to exercise for health. Thank you very much for your attention. And if you're interested in sports cardiology, you also learn an MSc at St. George's University of London, so feel free to have a look. Thank you.
Ευχαριστούμε πάρα πολύ για αυτή την, νομίζω, εξαιρετικά ενδιαφέρουσα παρουσίαση. Το αντικείμενο είναι εξαιρετικά ενδιαφέρον. Έχουμε μια ερώτηση από το κοινό, από τον κύριο Αυθονίδη, ο οποίος ρωτάει αν, σε σχέση προφανώς με το QTAF, αν χρησιμοποιείται πάντοτε τη φόρμουλα του Μπαζέτ, ακόμα και όταν το resting HR είναι σχετικά ψηλό, πάνω από 90. Να συμπληρώσω και εγώ ότι μιλώντας με τον Μάλικ παλιότερα, αυτός επέμενε να χρησιμοποιούμε το Φριντερίκε και όχι το Μπαζέτ.
Έχετε απόλυτο δίκιο, και αυτό που γνωρίζουμε ότι πιθανότατα το Φριντερίκε η φόρμουλα performs a bit better όσο αφορά το Brugada και την Tachycardia. Απλά τα περισσότερα data τα οποία έχουμε σε μεγάλους πληθυσμούς είναι με το Bazet φόρμουλα. Οπότε για τη βραδικαρδία, γι' αυτό έκανε τη συγκεκριμένη σύσταση. Τώρα, άμα είναι ταχυκαρδικός πολύ πάνω από 90 και ειδικά πάνω 100, μπορεί να χρησιμοποιήσετε και τις δύο φόρμουλες και αντίστοιχα να προσπαθήσετε να βγάλετε κάποιο συμπέρασμα όσο αφορά το QT prolongation που έχει ο αθλητής σας. Βέβαια, είναι αρκετά σπάνιο, ειδικά για άτομα τα οποία ασκούνται αρκετά συχνά, να έχουν υψηλού βαθμού ταχυκαρδία κατά τη διάρκεια ειδικά μη άσκησης.
Ευχαριστώ. Και μια πολύ γρήγορη ερώτηση από μένα. Η ηλεκτροφυσιολογική μελέτη έχει καμία θέση στην διερεύνηση των ασθενών αυτών?
Σε αυτή τη φάση όχι ιδιαίτερα. Δηλαδή δεν θεωρώ ότι έχουμε το evidence για να προχωρήσουμε σε ηλεκτροφυσιολογική μελέτη στη μεγάλη πλειονότητα αυτών των αθλητών. Για να είμαι εντελώς ειλικρινής, δεν μπορώ να θυμηθώ την τελευταία φορά το οποίο χρησιμοποίησα ηλεκτροφυσιολογική μελέτη. Πιθανότατα η εξαίρεση, και αυτό σε ερευνητικό κλινικό επίπεδο, ίσως για ασθενείς με Brugada syndrome, το οποίο υπάρχει κάποιο θέμα με το re-stratification, και πιθανότατα σε κάποιες περιπτώσεις η ηλεκτροφυσιολογική μελέτη να μπορέσει να σε σπρώξει πιο πολύ όσο αφορά τη χρήση ή όχι απεινιδωτή. Απλά και σε αυτές τις περιπτώσεις πρέπει να έχεις ένα σχέδιο πριν κάνεις την ηλεκτροφυσιολογική μελέτη και το αποτέλεσμα να αλλάζει το management αυτού του συγκεκριμένου ασθενή.
Πολύ σωστά. Κύριε καθηγητά.
Κύριε Παπαδάκη,